Okay, so the second part of the information related to the Rancho level is that Rancho's level 4 and 5 tend to be the very interesting stages of brain injury. And when a patient is in these levels, it is always a challenge for the staff. So Rancho level 4 is called internal agitation, and Rancho level 5 is considered an agitated response. So what happens in those patients is that they are internally agitated. Their whole existence is, you don't have to do anything, but just them being alive and breathing is agitating to them. So when we're talking about this, the next slide is that it really kind of goes over the different parts of the brain that are associated with agitation, and the fact that patients, depending on how their brain recovers, all brain injured patients do go through this stage. The sad part about it is that your way that you were before does not necessarily have any connection with how they recover. So you can have the little old lady who was a sweet grandmother and never cussed, but goes through the Rancho level 4 and now is cussing like a sailor and doing all kinds of sexually inappropriate things, and the family is completely horrified. They don't know where this is coming from, and it really has nothing to do with the little old lady and how she was before. This is just the part of the brain that seems to get activated as a result of their brain injury and their recovery. So, but I will tell you that the patients who were aggressive in the past and had dysfunctional type behaviors, brain injury doesn't, it's not like in the movies, it doesn't typically make you a better person. It tends to aggravate the things that you already have and make them worse. So if someone had a lot of bad behavioral problems, when they go through this stage, it can be exceedingly difficult. So this slide kind of talks about those different components. The frontal part of your brain is where a lot of your behavior comes from. So in the olden days, they used to talk about people having frontal lobotomies, and what would happen then is that they would actually do surgery and remove people's part of their frontal lobe, and then afterwards they were very flat in affect and didn't have a lot of emotion, and so their behavior changed. So the frontal lobe has a lot of components of the brain injury that if they're really agitated, that lobe of the brain is very activated, unfortunately. So with these type of patients, what you're looking at is a huge component of their care at this point actually has to be behavioral, whether you want it to be or not, and you're definitely out there trying to work with them and trying to get them to do other things such as, work on ADLs, etc. But the fact that they have to do ADLs is very agitating to them. So what happens is that a lot of times, no matter how hard you're working to try to get the patient to do and perform things that they need to learn how to do, it's very difficult at this stage. So what you have to do is actually monitor their behavior and work with them pretty exclusively on the behavior issues. So the goals of care at this stage are the safety of the patient, family, and staff, because typically their issues related to their behavior can become physical, and they really are verbal. If they can be verbal, they are, the word I guess I'm trying to think of is they can be sexual, they can be physical, a lot of grabbing, comments are anything and everything. So you spend a lot of time, therapists are trying to interact with the patient, trying to help them get out of the bed. They grab the therapist in inappropriate ways. Nursing that has to deal with bowel and bladder related issues, that becomes very complex in this type of stage of the game. This is when Patients literally will stand on the bed and urinate all over the room. They will take their feces and throw it, play with it. It's not a very fun stage for the healthcare workers, but it is what these patients have going on. So we do want to maximize all their good behaviors. Whatever we can do to try to reinforce good behaviors is what we try to spend our time doing, and we do try to minimize their bad behaviors. So you work on developing a behavior treatment plan. In brain injury, consistency is always extremely important for these patients. They do really well with the same routine every day. So you develop, literally a schedule for the day. You tell them what their schedule is going to be, and then you really need to maintain it. And for patients that really fixate on their schedule, if you do anything that deviates from that schedule, that will immediately cast them into the whole agitation and behavior problems. So you want to have continuity of the staff members as well. One, because it'll be easier for the staff members. They know how to consistently deal with their agitation, know what kind of things are going to be issues for them. And the other thing is that when a new staff member has to come in, that itself is very disturbing and upsetting to the patient to have to deal with these. The patient starts getting agitated just because you're somebody new. And the thing that's really crazy, I remember a patient that I worked with, is that they, on that particular day, I had on a red shirt. And this particular patient, red was apparently something, I don't know if her boyfriend wore red and maybe they had a bad experience or where red played into it, but I had on red that day, and my sheer existence to that patient was agitating. And actually, you have to be very flexible at these stages. And so I actually, went to my boss and said, hey, my charge nurse, and said, this patient is extremely angry, is being extremely aggressive to me. Do you think you could come in and try to talk to the patient? And actually, we ultimately changed the assignment. And I remember personally feeling horrible that I would have a patient that would need to have the assignment changed. But to be honest, the reality of it is that, my red shirt was a trigger. And, who knew? So you want these patients to have a lot of rest periods, because if they get tired, they get overstimulated, and that's a problem. You put the treatment times kind of in little pieces so that there isn't too much that is, if they keep going, they get tired and overexerted, and then their behavior comes out. And you want to use simple, familiar tasks, because this is not a great time for you to be actually challenging them with new learning skills. New is not what they're going to want to do. It really is a good time to reinforce the kind of behavior and the activities that maybe they've been successful with before. The hard part about all of this is that you have no idea how long they're going to last in this stage. So it could be that literally it might be a 48-hour period. That would be delightful, and that would be something that you would hope for. But the reality is that it could be that it lasts for weeks. And what you really don't want is, in brain injury recovery, people can get stuck in stages. And this stage is not a desirable stage to be stuck in. And that becomes a whole new level of fatigue of the staff, potential injury, the number of injuries that occur to staff members, patient injury, and possibly having to actually move the patient to other units to give the staff a break and let other areas take care of the patient. There's lots of things like that you need to do. So it says here, for behavior plan in the treatment, allow for personal space. They need to have time where they're down, as well as time where they have a time out, per se. It says provide frequent orientation and redirection. A lot of times when brain injured patients are getting agitated and something is triggering them, you try to redirect them and try to find something that maybe catches their attention and gets them off of the anger fixation and possibly onto something else. And the good news is that when you're a brain injury, you do have a short attention span, and so it's helpful, and this is when you can kind of play with that and kind of say, oh, bright shiny thing over here, and then they were fighting you one moment, now they're like, oh, look, and that's helpful. And using short, simple phrases is always, minimizing it is better. And eliminate all unneeded sources of stress. So, yes, you always want to keep your patients clean and dry, but reality is that sometimes you may actually, if you're trying to change them and if their skin is very intact and everything is okay, you might go a little longer in between the changing just because it's typically changing patients is not, that's a very stimulating activity, and so sometimes you need to reduce the number of times you have to do certain things, so you do what you can. So the therapeutic environment itself, you really, want to be in a place where they don't have lots of busy wallpaper on the wall. You don't want to have a lot of objects in the room. This is when minimalistic is very fabulous because you want to truly have a very decreased stimulation type of environment. So, not that you would change room colors, but pinks and, and not hot pink, but a soft pink and, colors that are really not stimulating is a better type of a physical environment. You want to have, like I said, minimize what's in the room. So you might just have the bed, a chair, a side table. You probably want to put something over the television because watching television and that stimulus can be a negative. So you probably take a phone out of the room because if the phone's ringing or they may use that as a weapon, there's all kinds of things that become a problem. Sometimes you actually bring the therapist to the room for therapy, and actually the patient doesn't go out much because remember, if this is a person that's being internally stimulated all the time, the sheer fact that they would go out into the hallway is a new and stimulating environment. There's a lot of things going on in the hallway. There's busyness up at the nurse's station. There's other therapists, other patients. That all becomes extremely stimulating to them. So what you need to do is actually possibly bring the therapist into them, maybe do therapy. It could be one-on-one, but would be better. Sometimes to having two therapists at one time so that you, again, limit that amount of stimulation. This talks about, is the patient ready to get all he can out of his day? Because the truth of it is that, at this point, limiting them is what's really going to be most beneficial and not doing a lot of stimulation. So it says here, no chatter in the hall outside the room, no vacuuming during therapy, no maintenance carts. It's one of those really crazy things that you and I may not even hear things, but they hear it, and literally like the maintenance cart wheels, we actually, I've had units where we actually had to change all the wheels on all of the carts because when they would literally have to move, they would squeak or they would stick or they would rattle on the floor, and so we had to do something like that to just decrease that stimulus. Obviously, the really bad downside of all of this is that these patients can become unmanageable. They can be very dangerous to themselves as well as to others around them, including family members. This is very traumatizing for the family at this stage. The family needs a lot of support emotionally because, the wife who was very close to her husband, now when they're together, like she may bring up, she needs to talk to her husband about finances. She brings up finances as something that they need to talk about, and the patient all of a sudden, because that's potentially a trigger, now gets very aggressive towards the wife, and that's never been even a behavior issue for them. So it's just something that's out there that you just have to be aware of. So when it says here, use safety techniques, use medications, and really what we're getting ready to talk about on the next several slides is going to be the kind of medications that work best in brain injury, particularly from a behavior standpoint. Because there are definitely medications that are better than others. And it's not a bad thing to medicate people at this stage because they honestly can't control this themselves. And whatever we can do to kind of try to help them learn how to control it is definitely a positive perk for them. So some people like to go down the route of the antipsychotics. Busbar is a medication that is an antipsychotic that can be used. We'll talk about some of the things that it does as far as what are the parts of the brain and parts of the chemical system in the brain. This activates the serotonin receptors, and what's nice about it is that it does not usually cause sedation. The idea of medicating someone is not to snow them. You still want them to be able to interact. Now, I say that sometimes when someone is just so completely out of control, you do have to sometimes kind of come a little hard medication-wise and get them down, because sometimes they're so fixated on whatever the trigger is or whatever it is that's making them agitated that the only way to get them off, no ability to distract them has worked, no getting them into a quiet environment works, that you literally have to kind of take out the big guns and do something to really bring them down. This would not be the drug that you would choose in a situation like that, because this doesn't really cause the sedation. So this one does have a very short half-life, only 2.5 hours. But one of the things you have to be careful of is that if the patient's taking Haldol or has had Haldol, it does increase the Haldol levels. So, that synergy is something that you have to be careful of. Benzodiazepines, and some of the drugs that we see in that category are your Ativan, Valium, Xanax type medications. Those activate the GABA receptors in the brain. Bad side effect or good side effect, always negotiable as to, depending on what your outcome and direction is that you're going for, what your goal is that these drugs can cause significant drowsiness and confusion. Drowsiness could be good, confusion probably not good, because these are already people who are confused, so they don't need to have more of that. The shortest acting of that group is the Xanax. It has a half-life of 15 to 20 hours. So I want you to recognize that that's the one that has the shortest. So these are medications that really last for a long time. So when you give a patient a medication like this, expect that they're going to kind of be, I don't want to say down for the count, but they really potentially could not be participatory now for many, many hours. It should only be used in brain injury for severe non-redirectable behaviors. So this is definitely, from the previous drug, this is a drug that if you somebody is just completely out of control, you may have to use your benzodiazepines. Dopamine blockers. And I did not actually personally create these slides. We talked about the content, and I mentioned this only because it says, now why on earth would you do that? So this is one of the comments that is, these are the drugs that we really would prefer that you not use in brain injury, because they have a long half-life in brain injury, and as you see here, it says it snows them for days. So these are drugs that we would prefer that you not use, because the part of rehab is to actually be able to interact with the patient and be able to work with them and do things, and you give them Haldol or Mellaril, and you might as well, maybe it's a great staph relief, but that's not what this is supposed to be about. We're supposed to be about, helping our patients, and these drugs are drugs that are going to really snow your patient for a long time. So we really don't want you to use these kind of medications in these patients. Now, I will say, with that being said, every human being is unique. And sometimes if you've tried all else and it doesn't work, this is another category of drug that you could try. The problem is, this was one you should absolutely save to the ultimate last, because in brain injury this tends to not be one that has positive effects. But it is in the gamut of drugs choices that are out there. So then there are the serotonin and dopamine antagonists. An example of that is risperidol. It has a side effect of drowsiness. It has a long half-life in brain injured patients of 20 to 40 hours. So what's nice about that is that the patient, you can give it to them, and then this will last for a very long time and stay in their system for a very long time. So this can actually be nice, where if someone needs to have an edge taken off and lasts with them for a while, this is a drug that you could use to do that. The things you do need to be careful about it is that from a cardiac standpoint and stroke patients, so people that have behavior problems with those additional problems, this is not a drug that you want to take with them, because of the side effects that involve the cardiovascular system. So you would need to be watching the patient from a medical standpoint if you're going to use these type of drugs. Sometimes patients need to have sleepers, and the reason why they need to have sleepers is that brain injured patients can get their days and nights mixed up. And the last thing that you want is someone who is awake all night and then sleeps all during the day, because the therapists and the neuropsychologists and their visitors and friends and everybody are coming during the day, and you want them to interact with them. You certainly do not want them to then at night be up and awake, etc. So sometimes these patients do benefit from having something to help them sleep at night. And some of the drugs that are out there are Halcion or Restoril. And remember, the benzodiazepines increase the GABA, and they have a longer half-life, versus Ambien is a benzo agonist. It also increases the GABA, but it has a shorter half-life. So, we would probably prefer that you use the Ambien when you're going to help a brain-injured patient sleep, because it's a drug that will help them go to sleep, but it's not going to make them have a hangover per se in the morning when they wake up. So there are medications that are historically known as blood pressure medications. Inderal is a centrally acting beta blocker. It blocks the fight or flight cascade. It helps decrease overstimulation, but again can be sedating. And then you have to worry about the patient's blood pressure and some of, again, those cardiovascular type things. But they also can be very helpful as far as a drug to help control the patient's behavior. So now we're going to talk about aspiration, which is a problem that does exist in the brain injured population. The scary part in the level 4 and 5, and to just speak briefly about level 5 patients, the agitation is not always present. In fact, more time they spend non-agitated, but when they get tired, when they're overstimulated, when they're over-challenged, this is when they actually start having problems, and then that agitated behavior comes back. So the way you know that someone's a 4 versus a 5, the 4 is they're agitated just pretty much all the time. There's not a whole lot of when they're not agitated. They have periods of being worse agitated, and they have periods of being less agitated, but their overall being is being agitated. In 5, their overall being is not being agitated, but when they have challenges of any sort, that's where their body goes back to. So when I talk about sometimes when you're documenting, people will say, well, someone, is emerging into 5. So I literally document, a 4 with an arrow to a 5, because they have some periods that let you know that they're starting to look like a 5, because they really do calm down. But then if you have someone who isn't in the 5 category, who maybe on this particular shift is not doing as well, then you would maybe have a 5 with an arrow down to a 4. Of course, that's when we used to be able to write things down, and now everything's in the computer and it makes you pick 4 or 5. Then you're just going to have to look at what their overall behavior is, and then what is it the majority of the time, and then you'll have to use that number. So aspiration becomes a very big issue in these patients, because one of the things that they do is that they are hungry and they want to eat, and they're going to eat, and they're going to grab anything and everything. If they're thirsty and tube feeding bottle is sitting on the side table, they will grab it, take the lid off of it, and then drink it. And that can also mean if there is a bottle of cleaner from housekeeping that someone left in the bathroom, that they would try to do and attempt the same thing. They're extremely impulsive, so you have to be very careful. And if they're hungry, they put lots and lots of food in their mouth. So they frequently need someone to sit at the table with them and regulate their eating, because it's like, okay, they could have a hamburger and chips on their plate, and they may, before they finish chewing the bite that they have in their mouth, they've already taken their next bite, they've grabbed 3 chips and they're shoving that in their mouth, and it increases their risk for aspiration. So these are patients that definitely have to be monitored. What this slide really speaks to is that it says store food in locked and separate areas. Totally agree, because they will be trying to eat anything. It says have maintenance shut off the water in the bathroom, because if they're thirsty, they're going to do anything to get a drink. I would hate to think that this would happen, yet I am certain that it has happened, that patients will drink the water out of the toilet. They will take the shower and turn it on, whatever they can do. So this really speaks to, have maintenance, turn off the water. If there's a water fountain that's in the hallway, again, you would potentially actually get that turned off, because they'll fixate on it and they'll just, I want to drink. They'll go over, they'll be trying to do it. They're impulsive about it. And you have to educate staff and visitors, because visitors come in, they may walk in, with a bottle of water, and the patient will try to grab it from them if they're thirsty, and won't just kind of drink it. I've definitely seen patients where they grab the water and they're drinking it, they're coughing and choking, the water's pouring down their face, and you need to take it away from them. And all of that, of course, causes all kinds of stimulation, and you get into a lot of problems. So for the protection of the patient and the staff and the visitors, this is really important that all people that interact with the patient understand that this is something you have to pay attention to. Again, if you think about the person who is extremely impulsive, they're going to be someone who's extremely at high risk for falls. So safety is just a huge issue at the stages of 4 and 5 of the Rancho scales. And you need to make sure that there are the least amount of things present that they can get hurt with. So if they're going to fall, you want to make sure that there aren't a lot of pointy surfaces that they can hit their head on. You want to keep the bed low. You might actually, I've seen patients in the Posey bed, which are the bedding, we call them Posey beds, but that is a brand name. But the truth of it is there are other people that produce these beds as well, but they're the ones that are the enclosed bed. And for those beds, they look like a poster bed with netting all around and on the top. And what happens is that those patients will get in there, and when they're agitated, I've seen them throwing themselves up against the side of the bed. They're actually built to be very stable on their four legs, but if the patient is really out of control enough, I know that the bed actually, if someone throws themselves up against it enough, they can actually knock it over onto the ground. Otherwise, I would tell you that a Posey bed is extremely good for keeping the patient safe. So when talking about Posey beds, I do want to recognize that Posey beds are considered a restraint, and that some facilities are not able to use beds like that. Those are something that we tend to like to use in the hospital environment, and sometimes in acute rehab facilities they will use them, but we do obviously ultimately wean the patient off of those. And if they're going into a subacute facility or somewhere where there's an extended care type place, it's not very likely that you would use that. What you might use, though, are what are considered low beds, which literally are, sometimes they literally take the mattress off of the bed and they actually put the mattress on the floor. Or they have a bed that's considered really low, and I've seen them go as low as like 12 inches from the top of the mattress all the way down. So pretty impressive as far as how low they are. But what's nice is that they also can be raised, so if a nurse or a therapist or someone needs to, the patient can't get up off the floor, you can actually raise the bed and then they can get off easier. You want to have these patients when they're in your line of sight and line of vision, because they are going to be someone you have to keep your eyes on. They're so impulsive that if they wake up in the middle of the night and they need to go to the bathroom, they're not going to say, wow, I have some limited walking capabilities and my right side is weak and things like that. So they're not going to recognize that piece at all. So another thing is that you want to toilet the patient and actually get the patient go in and do that on a regular basis, and not allow them to wake up and go, wow, I need to go to the restroom, because otherwise you're going to have danger of them falling. We always recommend a night light in the either bathroom or in the actual room. Beds now, some hospital beds actually are being built now that they actually have a function where there is a night light underneath the bed. And so that's a setting that actually can be turned on. It throws light just down to the floor. It doesn't give a lot of light in the room, which is good. But what's really nice about it is that it does provide some light in the room, and it certainly tells where the outline of the bed is. So when the patient moves about, they actually can see. So we also recommend that you give patients potentially a snack in the evening if they wake up. It might be a great opportunity to give them a snack, because if they're hungry, they are going to look for food. So providing it for them really makes things a lot more helpful. And we talk about, giving pain and anxiety medications earlier, and why that's particularly helpful is that this way you don't allow them to get agitated and if their pain starts to build, that's going to stimulate them, get them more agitated. So you actually want to give them pain medication, stay on top of their anxiety medication, because any amount of time where they start deviating from that, again, that's going to stimulate them, and so that'll increase the agitation. So I love this slide because it says, what about all these tubes? These patients are going to, anything that's not normal, they're going to remove. So if they have a trach they're going to try to pull the trach out. If they have an NG, well, they probably wouldn't have an NG tube, but they might have a PEG tube into their abdomen or a G tube, and they're literally going to pull at that. So, one of the things that we like to do is once someone gets a PEG tube, is that we actually put an abdominal binder around them so that they don't readily see the tube sticking out of their body and then try to grab at it and try to pull it. Out of sight, out of mind is extremely helpful for this population. The hard part about it is if they're not eating enough during the day and they need to have their meals supplemented with some kind of tube feeding, one of the things we recommend that we do is that you give that to them at night. Because while they're asleep and you have to connect the tubing, now you're connected to something so you can give it to them. Now, the downside of doing that is that if you're feeding them at night, they're going to have to go to the bathroom more at night, and they're going to be having more fluids, so they're going to have to urinate. So again, you got to weigh all that out. Just pay attention to, just think logically. If I'm giving somebody a bunch of water before they go to bed, they're going to need to get up to go to the bathroom. It's just logical. So this talks about one of the things that you want to do is keep things anatomically aligned. So as I mentioned, if you have a tube into your stomach and it, something is protruding out of your stomach and then it kind of goes off on the side, that's not normal and that's not usual. So if you, like for a catheter, you can literally run it down along the body and then down along the leg. But, if you have it pulled in an awkward direction, that's going to be annoying and agitating to them. And so that's going to cause them to want to pull on it and try to take it out. So you want to make whatever you've got going into them really be as comfortable as possible. And it says right here, PEG safety specifically, this is another great tip, is if you put them, they're wearing regular clothes, then tuck the shirt into their pants. Because obviously if the shirt is hanging open, then they can get their hands up under their shirts and then try to get at something. But if it's tucked in, that just increases the challenge a little bit more, and they will tend to not pull on it and have problems with that being there. I already mentioned the abdominal binder. You don't want to have a lot of bulky dressings because if they're feeling it and they're seeing it, they're going to be after it. So you want to really minimize what you've got on the patient. And, this talking about no stopcocks, so true, because if you have something with a stopcock on it and you put an abdominal binder on the patient, you're going to put something that's pretty hard up against their skin. That will become painful. Pain means agitation, and everything kind of snowballs from there. So the other thing that's bad about that is if they can get a hold of the stopcock, I promise you they will turn it to it being open, and what is in there will come out. So again, you really want to try to avoid something like that. So bowel and bladder. Big challenge. It's probably one of the things that sadly is the reason that I saw a statistic in a study I was reading that said the leading reason of why people are put into institutions by families is because of bowel and bladder issues. And because when people become incontinent, family members can't handle that. They don't want to have to deal with that. You may love your father tremendously, you would do anything for them, but now that your father has incontinence issues and you are taking care of him at home, now you kind of get into this whole private part issue, and that, daughters and sons, it's hard to take care of your loved one like that. It's a very different role. It's one of the issues that wives or husbands get into when it's a spousal relationship. Certainly with your spouse, you've definitely been exposed to them and their private parts. However, to actually have to be cleaning and dealing with incontinence, this puts a big challenge on relationships. So this is something that we try to work on establishing some form of continence, because this is really the make or break component of being able to go home. So a lot of times, as this says here, the patient may not be able to verbalize the need to go to the bathroom, so you have to look for signs. A lot of times what I find is that they start becoming agitated. So if the patient was kind of just hanging out, they were listening to music in the room, they maybe have a television program of watching running water and a stream video and some of those things that are very calming things, and then all of a sudden they start becoming agitated, they're wrestling around in the bed, they're pulling at things. They may need to go to the bathroom, but they can't verbalize that to you. So, you kind of go in and you say, Mr. Jones, do you need to go to the bathroom? How about we get up and go to the bathroom? Or how about you try to use the urinal? Just because that may be what the issue is, but they just can't verbalize and tell you about it. So right here, they display other signs like wiggling around, removing clothes, trying to get up. Best solution, take them to the bathroom. So it's very helpful. So one of the things we talk about really that is key for the safety of staff members, the safety of the patients themselves, the safety of the family or any visitors, is really education at this stage, and having everyone understand that this is a stage, that this is unfortunately a stage where they are difficult to be around. That doesn't mean that we don't love them and that we don't want to take care of them, and we need to have a lot of compassion at this point, but they are very challenging. And if the boss comes to visit the employee and they maybe got a head injury at the workplace, and they come when they're at a stage 4 or 5 visit, they need to be prepared that this is not that, Mr. Smith is now a terrible human being, or that they're taking out agitation and aggression on the boss. This is just something that has happened. So we say here that, we need to educate them to all the different components of safety. They might swing at you, they may have sexually inappropriate, try to touch you in certain ways that are not comfortable. They may do inappropriate toileting. They will grab at things, they will throw things. Any object is a projectile object potential. So, everybody needs to be educated to this all the time. Maybe a sign on the door or something that says, is a little bit of a cue that, please help me. I, have safety concerns. Make sure you check with the nurse before you go into the room. Anything like that can be posted. So, and one of the things that it says that I think is such a valuable lesson is that the last bullet point, which says, don't forget to teach the family that it is okay to walk away from bad behavior. None of us deserve to be abused. We do have to take care of these patients. So sometimes we do have to tolerate a period of, if you're cleaning somebody up, they can be saying all kinds of horrible and nasty things. But I think the most important thing to remember is that this is not personal. And a lot of people struggle with that. They do think that it's personal. I think that it's an important lesson to work with our tech staff about specifically, because the licensed professional staffs get a lot of education and training to understand this, and sometimes we haven't really paid due diligence to our tech staff and assistive staff, the housekeeper, to know that when she goes into the room, the patient might say or do all kinds of things, and it's not about them. This is about that maybe they rolled their little cart in and the wheels made a noise, and then they're going to clean some things, and they're going to change the bag out, the liner, take the garbage out. All of those things make noise, and the patient may just get very agitated. So it is what it is. Nobody has to stick with it all the time. Like I said, you do have to interact, but what you need to understand is go in, do what you need to do, and get out. You just don't need to stay. And same thing for family. If their loved one is really giving them a hard time, they need to know, and they actually need to hear from us that it's okay to walk out of the room. and to walk away and take a time out yourself. And actually that's what's good for the family member too, or for the patient, because they're triggered, and this would be a good thing for them to calm down. So the road to recover, Rancho levels 6 and 7. These stages are really very wonderful stages. This is when the patient is really no longer being agitated. On a day, like if they had a lot of big activities, a lot of physical challenges the day before and they're tired, remember that brain injured patients regress when they do have problems. They tend to go in the opposite direction. The good thing is that once you get into the 6 and 7 level, they regress to a 5 level. Okay, that's good. A little bit better than regressing down to a 4 level. So moving forward, these are definitely just a much more pleasant. These patients are still different. So if anyone met them, they would be like, there's something not right here with this person. But they can be extremely functional. They actually, with a really solid routine, can go out and participate in the community. They're better, but still impaired attention. Again, bright, shiny thing can quickly, that's right, distract them in all different kinds of directions. But they are capable of learning new skills, which is incredibly wonderful. But as I said, they do have a low frustration tolerance. So if something's really challenging to them, they're going to want to kind of shut down and not do what they need to do. They do still lack insight into their impairment. So a lot of times they don't recognize that this is a shortcoming. I remember a patient that I had who she had a really inappropriate laugh. The way that it sounded, the way that it came off was made you uncomfortable. And so when she would have people around her, that people didn't want to stay around her because it was kind of uncomfortable and awkward. For people who are typical, being around that was very odd. And so she didn't get it. She didn't understand that. And I remember when she started getting up into the 8th, Rancho level 8, how she started having a sense of that, of her laughter being inappropriate. And you could see how she would try to calm it down and actually recognize, I'm laughing kind of out of control. I need to pull it in. So again, you see that as you get into these higher levels. What you love is that increase the time the patient is left unsupervised. They actually can be left alone, which is wonderful. You still want to have a safety room, so if they do get overstimulated, they have a place that they can take themselves to go and have a timeout. And it says here, remove footrests from wheelchairs because, again, impulsivity continues to be a problem. These people are going to want to be able to get around on their own, and if they can, the foot pedals need to be out of the way, and they can foot wheel themselves wherever they want to go. As their attention does improve, you want to increase distractions. So it's okay to have more things in the room. This is when, if the family wants to have pictures of the family and have the gift cards up on the wall, when we hit stage 4, we take all that stuff down. Now they're at this stage, that stuff can go back up on the wall, and it's okay. And in fact, they enjoy it. Everyone enjoys it, and so you can start increasing that kind of things. They will require less cueing at this stage. You can increase the complexity of their tasks. You can incorporate new learning. They start having self-management, and they increase their awareness of others. So really the things you're going to be able to see at the 6 and 7 level are going to be that these patients are capable of, you see them have new learned behaviors, and that you see them starting to have insight into themselves. So, 5, definitely no insight into themselves, quickly regresses to 4. A 6 doesn't really have insight, but as they start having more insight, you're moving more into the 7 category. So again, that's kind of how you differentiate between the 5, the 6, and the 7. Team communication is really important. Consistency is always, this is think about having a teenage child and how important it is to have mom and dad on the same page, because when mom and dad are not on the same page, this type of individual is going to go play one individual off of another. So working with this type of person is like having someone in a 6 or 7 level is like having a teenager. So it's important that everyone be on the same page. Therapists, nurses, doctors, that we all know what's going on, because when the doctor rounds and the patient says, oh, the speech therapist says that I'm allowed to have thin liquids now, and I'm really thirsty, and the doctor says, oh, great, and then gets him a glass of water, and then the speech therapist walks in and is like, what's going on here? And they're starting to do those kind of things. So they're starting to get a little bit trickier, and that's good. We should be happy that they're getting to have more insight and things like that. But that means we've got to up our game, because they're going to, that consistency is going to really be important. Again, routine continues to be an important thing. Really in head injury, that is always the case. Routine is important. So it says the routine is 24 hours to make sure all disciplines, all shifts are doing the same thing, which is really important, that the night shift and the day shift are on the same page, because the patient's going to take the opportunity to challenge all of us and to see if we're all on the same page. At this stage of the game, medication-wise, medications like Ritalin is a really good drug. It does stimulate the reticular activating system, and this may also increase serotonin. The side effect is that it does have central stimulation, which is the fight or flight part of our systems. It may increase or decrease the seizure threshold. So if you start a patient on this medication and all of a sudden they have a seizure, and you had never seen them have a seizure, it may be that they have the potential for seizure, and now that you gave them this was what it took to kind of kick that off. So it's just something to be aware of. I will tell you that we do see Ritalin being given to patients earlier than stages 6 and 7. Sometimes when we have patients at a stage where they're actually in Rancho level 3, we do things to try to increase their awareness and their focus. But we do it at this stage of the game as well, because it actually helps them, they are in these stages like someone who has ADHD. They're very active, they're highly distractible, and sometimes these medications really actually help them focus better and do what it is that they need to get done. And what's nice about these medications is that they have a half-life of only 2.5 hours. So you got to think about that when you're strategizing therapy schedules. But it's also another thing that, depending on how they react to it, it's not like it's in their system for a super long time. Another medication is Cylert, which is has a mechanism of action that we're not exactly clear, like we're not sure what it's stimulating chemically in the brain, but it is similar to Ritalin in its effect. There are less cardiac side effects. Sometimes with some of those other medications, the stimulation can have cardiac effects. It can cause people to have racing in the heart, and that can obviously have its own set of issues. The thing about this medication is that it has a half-life that's 12 hours. So again, that can be wonderful, because to try to help someone who needs help with focusing, this would be a drug that you could give in the morning, would potentially last them all day. So that's just something to think about. Something that I feel like I'm seeing a lot more in clinical practice is amantadine. We see that being used a lot. It's a dopamine agent. It increases dopamine levels. The best results in clinical trials were the use of dopamine agents, but you do have to be careful that it increases blood pressure. But amantadine seems to be a really nice drug. Patients seem to tolerate it well, and it does help them with their ability to focus and to kind of stimulate their mind to be able to do activities and challenges that they have. Bromocriptine is another dopamine agent. As you can tell, this has a little bit different mechanism of interaction in that it does not metabolize into norepinephrine, whereas I think the other one that we had some of that effect. It has been found to be very effective in neglect syndrome. So for the patients who look over to one side of the room, have visual field cuts and don't pay attention to the other side of the room, and then even ignore body parts and don't see them, you can actually give this medication and it helps them have an increased awareness. Oh, I do have a left arm, and oh, I need to pay attention to my left arm, and oh, my left arm's hanging in the wheelchair, in the wheel, and oh gosh, let me grab it and pull it out. They actually start to recognize those other parts of the body. But again, you have to be careful because of it affecting blood pressure and dropping blood pressure. Serotonin agents, Zoloft, Lexapro, Paxil, Prozac, great drugs, really, really great drugs. And what they do is that they can cause you to be sleepy, but they again help you with your ability to focus. These drugs are also medications that we know have help with pain management. These drugs, I mean, the serotonin agents are now being used for all kinds of different things, not just depression, not just anxiety. They really can be very helpful to people. The problem is that they take, this says 7 to 14 days. I would tell you that I've seen it be 14 to 21 days before they actually take their full effect. And so you're going to have to be doing something else while you're getting these medications up to speed. And it says may affect appetite. Again, with some people it may decrease their appetite, but for a lot of people it stimulates their appetite. And so then you have to worry about weight gain. And remember, if you have these patients who are impulsive, now they're eating food and now they want to eat food all the time, and so that can be very problematic. So trazodone particularly is a medication that has opposite side effects of the other SSRIs. It does cause drowsiness, and this says give at bedtime to promote the sleep-wake cycle, and you want to give in small doses for mild agitation. So trazodone has some wonderful effects, and it is a great drug to use, but it does cause more drowsiness than some of the other SSRIs. There are also the drugs these are multiple neurotransmitter agents, and that's because they actually affect serotonin levels, dopamine levels, and norepinephrine levels. Each of these do one, and I don't remember which one does which, but you know, one does serotonin and dopamine stimulation, another one maybe does the dopamine norepinephrine, and you have to look for the combination that really does work better for the patient. But remember, this takes 14 to 21 days, so you have to wait that long to see what the effect is. Maybe the effect doesn't look like it's working the way it needs to, so now you got to change over the other medication, and now you're looking at another 14 days before we get there. So that's obviously problematic. These drugs are great drugs, but this is a long-term process to get these in place. And again, they can increase blood pressure and heart rate, and they also can decrease seizure threshold. There are the cyclic antidepressants. The tricyclics are Elavil, nortriptyline, desipramine, are all medications, Remeron. It increases serotonin and norepinephrine. They can be very sedating, so if you're going to use your tricyclic medications, just recognize that they can be very sedating. But these are specifically some of the ones that are used in pain. I would tell you that I see these drugs used in neuropain all the time, not just this, all of these SSRIs really are becoming very popular in their use for pain medication. And clearly someone who has a brain injury has a reason to have nerve pain problems. I mean, their brain is part of the nervous system, and so this is something that's very helpful to them. MAO inhibitors, it says it increases multiple transmitters. They have a lot of side effects. They have lots of restrictions as far as diet. These are not typically a good drug to use in brain injury. Again, it's one of the many choices that are out there, and maybe you'll have a brain injured patient that really responds well to this, but really in general, we would recommend that you not use these medications for brain injury. So what I have here on the last slide is education for discharge, which, you know, ultimately our whole goal is to be able to return these people to their community, if not their community, into an environment where they can have some level of independence, whether that be in a group home type environment, but somewhere where they actually can have somewhat of a lifestyle and life that is independent and gives them the feeling of self-worth that they have that independence. So when you have that kind of thing, know that what's out there are day programs, there are outpatient therapy programs, adult daycare, home health. There's lots of community resources. But in these type environments, recognize that they only are for parts of the day. They're not for the whole day. Group homes obviously are for the whole day, but a lot of these type programs are you go for a certain amount of time and then you come back to another place where you may need to be monitored at that environment. Again, the closer you get to being at a 7 and 8 level, the increased amount of time that they can actually spend time alone. So the other thing that needs to be the last thing that be remembered is that there are support groups. The family needs a support group. The family needs to have a place where they get a break. They may need respite. The patient now may be at a place where they want to go to a support group where they interact with other people similar to themselves who've experienced some of the things they've experienced. And so it's time to actually start looking into that and actually provide them with resources and things to look into when they're out of the hospital or out of the environment that they are in. So remember that safety is always of the utmost. It's always our top thing because these people can really be at risk for doing dangerous things because of their impulsivity, because of sometimes their lack of insight. Sometimes, you know, they get a great idea, it comes into their head and they want to act on it right now. And so there are a lot of things that, you know, if you have someone who used to be able to drive and maybe now driving is not something that they should be doing, leaving the keys to the car just laying around is probably not a good idea, and that they, you know, will want to get in the car and they will try to drive. And so you have to be really careful from a safety perspective. Hopefully we'll have solved some of the continence issues by the time that they would actually be going home, because as I mentioned, incontinence is a leading factor for putting someone back into an institutional environment. Family and friends and the patient need to know how to do transfers, how to do their activities of daily living, because that's all a part of living out in the world, and they need to know how to do it. Sometimes patients' homes have to be modified. You know, if someone's still in a wheelchair, and they have 2 or 3 steps to get in, that's an issue, and you've got to provide a ramp to do that. If all the bedrooms are on the 2nd floor and they're in a wheelchair, then you may need to turn a dining room or something that was an office maybe down on the 1st floor into actually being a room for them to become their new bedroom. Certainly behavior strategies, again, understanding that fatigue and too many challenges are going to cause someone to regress. I think that even happens with all of us. We're not on our best behavior when we're really tired, and brain injury is really no different. The sad part is that their behavior just might be more accentuated. So you just have to be aware of that, and the family needs to be really in tune to that being an issue. So that's it. The next person will be presenting on some more topics in brain injury, and I hope that everything that I've said has been really helpful to you. And if you have any questions, to know that you should reach out to the Brain Injury Association for follow-up. Thank you.